Okay, I feel like I should have a theme song and a coined introductory phrase, but Mark, you truly are the second macro healthcare guest that we've had. We've been podcasting for 3 years now. We've done about 45 CEOs, but we've only been podcasting big thinking questions and big thinking minds for the last 3 weeks. And so haven't quite worked out the big macro theme song, but it's such a pleasure and such an honor to have you. And hopefully you'll forgive the creaks and the sounds of our ragtag operation as we get through this.
That's okay. As long as you forgive the creaks coming out of my knees and my shoulders and my elbows, then we'll be okay.
Okay. All right. We're gonna jump straight into it. I'm gonna skip your introduction because
Fine.
anyone who doesn't know you should
They're not
just
going to listen.
go
Yeah,
online, man. But
yeah.
I will say this, from my perspective, um, innovators at your level play a really important, healthy, positive role in our society, not to be understated. You're not pretending to create great things. You have a history of actually solving big problems, creating a lot of value. And fundamentally, I think that's the brand. So I know I've seen you in Shark Tank deconstruct opportunities like a ninja with a sword, cutting up sushi business plans. But fundamentally, if you look at your career, the last 40 years, it's one large insight followed by a big build after another. And by the way, Patrick and Sivan say hello.
Oh, yeah. How do you know them?
They're two of my best friends.
No way.
I'm going to spend this Christmas with him.
No way.
Yeah, yeah.
So get him to bring you to a Mavs game. That's awesome. Are you
I
based in
will
Vegas?
actually take public credit for the transaction that took place because in 2010, when Vegas was collapsing, Patrick will attest to this. I sat him down and said, stop feeding off what your father-in-law built and go build something in a new direction.
And Patrick's smart enough to do it. That's for damn sure.
Yeah, I think he listened. I'm taking full credit. All right, we're getting
I'll
into
give it to
this.
you.
So
That's crazy. That just changes everything.
yeah, I had to debalance you somehow. So now, with that said, the big topic, the big headline, and I'm a headline kind of guy, is U.S. healthcare. It's broken, according to Jon Stewart, as of 7 days ago. It's clearly unsustainable. I disagree with all of that. I think that's a trope.
Mhm.
And I'm going to spend the next hour or two trying to prove that to you.
You don't have to prove it to me. I mean, I can see there's a lot of reasons why the U.S. healthcare system is great,
Yeah.
right? But like any other business, if your customers don't think it, then you have a communication and other problems that you have to deal with.
And we do have a communication problem because we have been labeled clearly unsustainable, worst in the world, irreparable, broken by one author writing a long book, chapter after chapter, study after study, by one journalist, by one politician after another.
Yeah,
And
and I really try not to deal with things like that at all. I look at it and I say, what's the problem we're trying to solve?
yeah,
And the problem we're trying to solve in this particular case is getting people the care they need when they need it in a way that either they can afford or it's paid for in the manner that they're healthiest so that the overall net impact on society is positive rather than negative. That's it. And then you just work backwards from there.
spoken like the true innovator, entrepreneur, problem solver that you are. But here's a couple of problems for you. One, if we don't focus on the macro communications problem, the PR problem, which sounds incidental, the industry that we're in here, and I've been in it full time for 15 years, which is not forever, but a little bit longer than you.
A little bit.
And what I've noticed is they will actually take our toys away. They will make it harder for us. And for us, our toys are building. They will make it so much harder. Things like single payer, things like only government as a counterparty, as a client, one customer, things like anti-profit all the way through. And
Yeah,
then
that's all Michigas. That's all Michigas, right? That's all
they've
just
come close.
well, yeah, because again, it's just who can sell better, and what do the American people perceive
Yeah.
from whatever it is that they're hearing. And the bottom line is, if you have a bunch of customers, the American people, who aren't happy about what they're getting, and you can't expect your customers to do an analysis to compare the options they have to what others might have.
Yeah.
You know, we don't even do that well from state to state or city to city, let alone country to country. So I don't get all caught up in, well, Norway has got this, so we should be like Norway,
Yeah.
or the cost per person, or our medications, our brand medications are, you know, all these countries buy them for less, without knowing that our generics are less here than they are over there. You
So
know,
let's take a step back.
uh-huh.
If I was to just ask you point blank, where do you think we rank as a country, our healthcare industry relative to the rest of the world? Instinctively, what would you say?
I would say that there's not something that you could evaluate, because, you know, every individual is different. So your age, your demographics, where you live, your circumstances, what good health means in ranking is going to be different. Japan has a different set of issues because they're a homogeneous population. You know, we are a very diverse population. Norway is becoming more diverse because of immigration, but yada yada. UK is very diverse, so it's very difficult. And then when you look at what, you know, they did with the NHL, that was started in 1948, right after they just had got everything bombed to hell, right after World War II. So different set of circumstances, different expectations. So I don't think, you know, so all these ratings and scaling, I think they're useless.
I would agree with you 100%. In fact, read a really good book about it recently by Dr. Ezekiel Emanuel.
Yeah, I know Zeke and I don't always agree, but I just did a panel with him 2 weeks ago.
Yeah, we don't always agree either, but I have not done a panel with him. He just doesn't know that we don't always agree. And I want to show, but he did actually write a really good book. And the book was called Where Does the US Rank Globally? And that was the whole book. And his conclusion was hard to tell.
Pretty much just what we just said, right?
So I want to show you a few slides, and then we're going to double back to cost plus.
Okay.
So just managing your expectations. So we're going to start at the beginning. This is our global dashboard. It's free. We have fun building it. It's been evolving over time. We are more obese than most of our peer group. Everybody knows that. Intuitively, everybody knows that. It's not spread equally, by the way, across America. Different states.
And the growth of our obesity has grown significantly. Until this year, we've outpaced every other country by far.
We're getting close to putting a blame on this. We're arriving at Nixon in the 70s and the introduction of new corn laws that introduced cornstarch into a lot of our food products.
Oh yeah, look, you don't even get me started on the introduction of all these things that helped manufacturers. But
our food is different than everyone else's, and I can say that as a European who moved here. And honestly, I moved here 2 months later. This was 30 years ago. I was 20 pounds heavier.
One of my best friends that I started broadcast.com with, a guy named Todd Wagner. And he has an organization called foodfightusa.com. And they're partnered with Yuka. You know, Yuka is an app that you can download to find out, just scan the barcode and find out whether a food has processed and all in bad ingredients and all that. And so there's, I forget all the terminology. He's gone through it with me. But the rules for determining what's appropriate in a food in Europe and the rest of the world are completely different. It's all self-regulated here, and it's ridiculous.
So I once wanted to write a book and came close to writing it. 10 companies we could live without. But I didn't publish it because I knew it would be career ending. But the research was, and by the way, someone did end up publishing that book, and he got sued by every company. The research was staggering. This was when I was a banker and I had access to all the articles ever written about a company going back 50 years. And so I read tens of thousands of articles on all these companies. I didn't have anything better to do. I was a lonely child. And it taught me a few things. The same way that reading chronicles of the 20th century teaches you a few things. Every article published every day for an entire century. And so what did it teach me? The American way is libertarian first, freedom of choice. It's in our DNA. But it creates a blind spot. And the blind spot is not, information doesn't travel equally in all directions. And so those who are best informed
choice. And what I always say is there's not freedom of responsibility.
Right.
You take the choices but we don't take the responsibility and we pass them off on others.
Yeah. But the pressure on education, the more freedom we have, the more educated we need to be, and we don't always get that right. So let's go back, because this thing goes forward whether I want it to or not. It has a mind of its own. So I'm going to do this quickly, otherwise we'll be here forever. So physical inactivity, we don't do so well. This is us.
Right, it's getting worse. Yep.
Right here, physical inactivity. And that's, again, not equally spread across the country. As a result, diabetes, everybody knows, worse than everywhere else. By everywhere, I mean our pay grade. Heart disease, mortality, worse than everywhere else. What's interesting is our life expectancy based on income is comparable the more income you're talking about. So this idea that our life expectancy sucks is actually
Yeah, and that was a big part.
relative.
That was like the opioid problem, and so
yeah, but this I think predates that. That's 2019, right?
no, it was before then. But I get your point. So go ahead.
Yeah, so different parts of the country, we have some of the highest life expectancy in the world, depending on which county. We have 95 life expectancy in Southern Cal. And that's not the only part in America. So it really depends. Number of hospitals in America in 1970, 8,000. Number of hospitals today, 5,000. Population almost doubled during that same period. That creates monopoly power, leverage power, and pricing on its own. Less hospitals, more people. Our life expectancy in aggregate is poor, but this should never come out of our mouths. We should never compare our life expectancy to other countries. We should compare different segments within our country's life expectancy to other countries.
Yep.
And other countries should be qualified. New Zealand is the size of New Jersey. It's the size of half of New York. So why are we comparing 350 million people to half
obviously
of New York?
It's a lot easier to manage, 8 million or whatever, 14 million versus 350.
This is the most important slide we have. Cost curve in America got bent in 2008, 2009. Hasn't moved since then. This is as a percentage of GDP. Still 17.5%.
And Zeke Emanuel will tell you exactly why that happened, right?
He'll take credit.
Yep.
ACA. Right?
Yep.
The exchange. Uninsured, we talk about insurance for everyone. Today we're at 8% uninsured, 7 to 8%, right? Used to be 15%. We take no credit for that.
It's actually lower than that if you remove
illegals.
Yeah, illegal immigrants. Yep.
Which is a third of it.
Yep.
Yeah. By the way, when they say coverage for all, they mean Medicare for all. And when they say Medicare for all, they mean single payer. So I'm going to come back to this.
The Medicare isn't really single payer because the hospitals take on the deductible risk paid for by the patient. So it's not really single payer in the Medicare we have today. And even Medicaid to a certain extent is not.
Which is why they're driving up prices. One of the reasons.
One of the reasons, yep.
And you see the drive up in prices over here. It continues unabated. 6% hospitals, 6% nursing homes. Annual increase. And this is recent. This is the last year. Health insurance premiums down. Physician increase less than inflation. And by the way, most doctors will tell you that their true income has stagnated for the last 15 years.
For sure. And on the health insurance, a lot of that I'm guessing has to do with Medicare Advantage, because where they push down the premiums and restricted care.
And they're paying less and less for it. Yep.
Yep.
17.5 million people employed in healthcare, largest employer in the country, unabated growth. I mean, it's wonderful that a lot of people have jobs, but it's not great that we're overspending. So this is an issue for us. We have to think about it. Corporate healthcare blossoming. This is the private equity space, the MSO space. 120,000 physicians now employed by what's called the MSOs, managed service organizations. It's a new world. It's a revolution.
Yeah,
no one talks about it. This gets interesting. Cancer survival rates. Breast cancer. Who's number one? United States.
Yeah, wait till we come out with a vaccine and fight over that.
Lung cancer. Who's number one? Survival rates. United States. I mean, we throw around these statements like foreign wealthy people come here. Well, they're not stupid. Liver cancer, number 3. Not last. Heart rate, heart mortality, heart attack mortality, which was referred to as myocardial infarction, coming down significantly pre-COVID. Post-COVID, I can't speak for. Rate of heart attacks across the country, more than 2 times greater over here than the rest of the country. This is a hotbed for chronic illness. It's not the same everywhere. Inpatient readmissions plummet 2013. Ezekiel takes credit. I don't know if he deserves it. Cesareans, a point of huge contention for years, came down. This is almost reminds me of diabetes and insulin. Enough people complained, something was done about it, right? And then the spend, this is one of the most interesting charts of all. I don't know if I'll be able to freeze it, but we have a completely different spend than Europe. Totally different. And you can go through each one. Each one of these is a story, right? Admin, they're at 3.75. We're at almost 8% of our total healthcare spend. Totally different. Long-term care, they're at 20%. We're at 7.5%. We have a totally different approach to long-term care. We basically don't want to spend money on it. So let's hope that our
they
home care
also,
improves.
their opinion on dying and your last year is completely different across the world than we are here.
Yep. Different systems. Here you are, and I think you responded to this. You reacted to this and said, surely I can do something about this. Why are we spending more than everywhere else? And on paper, it looks absolutely crazy. And we're going to dive into that with you. Hospital prices continue to increase unabated, like cost of college tuition here in this country. There's nothing stopping them. I agree with you. Insurance companies, they raise premiums. It's all good. Hospitals raise prices. It's all good. But it is interesting that in other parts of segments of healthcare, which is the majority, hospitals are the minority, right? They're a $1.5 trillion spend out of 5. The rest of healthcare, other than drugs, so call it $2 trillion altogether. So the remaining $3 trillion is actually somewhat deflationary, has gotten under control. So we have had success. This is fabulous. This is for us. You know, we are providing nurses. We talk about the UK as something to emulate. Where are their nurses? On a per capita or per 1,000 capita basis, they are understaffed, under-resourced, understaffed. And it's not a surprise that with that, you have multi-year waiting lists, hundreds of thousands on 3 to 4 month waiting lists, and lots of negative outcomes as a result. Patients on waiting lists are not getting care. So this is restriction of supply by underinvesting. I don't know if we have this here, but most people don't realize that while we've remained flat in total spend for 15 years, the rest of Europe has not. Their cost of care as a percentage of GDP has climbed. And so that spread is actually narrowing. If you take out the obesity component and normalize for it, if you take out the extra drug component and normalize for that, so now we're talking adjusted EBITDA, which is language you know. If you adjust those two pieces, you end up with more or less the same spend. So it's not so complicated. Healthcare is so complicated. We can't explain it. We can't explain it.
Well, it is complicated. I'm going to disagree with you. It's complicated because the systems we use complicate it, but it doesn't mean it's not effective in certain areas, particularly relative to other countries, because they have they have their own versions of the complications.
It's incredibly complicated, but I'm testing you. So some really interesting stuff. Adoption of EHRs. Who ranks first? We do.
Well, we mandated it too, yeah.
Yeah. And by the way, who engages in value-based care, coordinated care, actively, professionally? We have companies in America that only do coordinated care. They don't actually treat patients. That concept doesn't exist in Europe. They can't imagine it, value-based care. It's all fee-for-service. We spend less on long-term care. I want to get to, unless I already skipped it, wait times. So I think
it hasn't come through.
Yeah. Our wait times, dramatically shorter.
For sure.
So given all that, are we as bad as people say we are?
Yes, but from a care-wise
On a
perspective,
relative basis.
yeah, on a care-wise perspective, no, we have the best care available. And so when you have the best of everything available, you can't ever say that you're not as good. Because when it comes down to it, if you're the one that's sick with something, you want the most availability, you want the smartest people, you want the best equipment, all of that stuff. And so I'm not going to say we're not as good, but that doesn't mean we're not a mess. And we're certainly a mess. And particularly, as I said earlier, when patients, families don't think they're getting good care or don't trust the system, that trust component defines our perspective and how we think about care across the board. So there's a lot of things that have to change. And, as I look at it as an entrepreneur, there's a lot of things that can change because so if you bifurcate it, right? Do we have the ability to provide the best care in America? Yes. Or in the world? Yes. Do we have the tools to provide the best care in the world? Yes. What's the challenge that we have? The payment functions and the restriction functions, right? Because they go hand in hand in some respect. So what are there things we can learn from other parts of the world that can make us better at figuring out the economics of how all these pieces work? And the answer is yes.
So I agree with all of that. I think it sounds nuanced, but I do think there's very different channels that you travel down if you start with break it all, rip it all, and we're the worst.
Oh, I never say that. Yeah.
No, I know. But that's the theme of this podcast. So you're going to be on the side of those that are with me.
Okay.
And the other side to that is not we're all good, leave it alone. It's rather actually healthcare in every country is problematic. No one has really solved for perfect healthcare. Every country has a ton of work to do. And given that we're 350 million people and still growing, which by the way is a big statement because you certainly couldn't say that in Japan or China.
Right.
Given that we're a big country and still growing, and we have such high expectations, what I love about being American. I've only been American for 30 years.
Congrats.
America sets very high standards. We're nowhere near the standards we want to be at. Nowhere near. That doesn't mean that we're worse.
We're a country of entrepreneurs. That's what entrepreneurs do.
Yeah, that's why we're here. That's why so much talent is coming.
Yep. That's what makes our country different than every other country in the world. We like to innovate. Every single kid has an idea. That's why I did Shark Tank for 15 years.
Yeah. So I'm going to invite Bernie Sanders, Elizabeth Warren, all the worst critics of healthcare I could possibly get my hands on. I'm going to invite everyone. And hopefully, if we're lucky, they walk away saying, we don't have to hate U.S. healthcare to improve it.
Yeah, but you know what? I don't even care about hate or not hate, Roy. I mean, it's not about that. The question is, the things, what can we fix? And what are the problems we have to solve? And how do we get there? I'm not against single payer. And in fact, I think single payer is a great option. The question is, how do we get there? And what's the path to getting there? And how do you enable it? Like for my employees at Cost Plus and some of my other companies, if you get care within the network that we direct contracted with, we are single payer to you and your family. We will cover everything. There's no deductible, there's no copay, there's no co-insurance, there's no pre-authorization. If you work for me and the hospital down the street that we contracted with can take you and care for you, that's it.
Isn't that true for any insurance policy that anyone buys that's pretty exhaustive? It's called full coverage.
No, not at all, because there's still an out-of-pocket at some level for the employee and their family.
Sure.
So you're going to have a copay, you're going to have a deductible, there's going to be something, and that's a whole nother argument.
But I think that's very different than single payer, where we've taken choice and variety out of the market.
Let me finish the concept, right? So yes, it's not national single payer, but the point is that how do you get to national single payer? And what are the steps that are taken? The first step is to define all the costs and have those costs be in an efficient market. Because if it's not an efficient market, government's not going to be able to negotiate anything that's valuable enough to serve the purpose, because they're working from a deficit of information. That's one of the challenges. You see it on the drug side and you see it on the care side, because nobody knows what everybody else pays. And nobody knows the considerations that come along with those payments. So, when you look at a hospital contract, a direct contract or an insurance contract, they have all these stipulations. If you're in the hospital for 8 days as an inpatient, then the price goes up to X. And if you stay 3 more days, then it's X times 1.27643. And then, so all these complications and all these contracts, the first line in the contract is like Fight Club. The number one rule of Fight Club, you can't talk about Fight Club. The number one rule of healthcare contracts is you can't talk about healthcare contracts. And so we are in an inefficient market. And so the first step is, how do you make it efficient so that everybody has equal access to information? You saw what we did with Cost Plus Drugs.
Let's go into that.
Yeah. So if you go to costplusdrugs.com and you put in whatever drug it is, imatinib, tadalafil, whatever it may be, you're going to see our cost. You're going to see that we mark it up 15%, and that's the same for everybody. There's a pharmacy fee of $5 if we ship it to you, plus a shipping fee of $5. And if you pick it up at an affiliated Cost Plus pharmacy, we charge you $12 for the pharmacy fee, because we want the pharmacist to make money. So it's a little bit more expensive because you're paying for their time in that relationship. But the most important thing that we did, and it wasn't even intentional, like we knew this was going to be the most important thing that we did, we published our price list. And when we published our price list in January of 2022, we only had 111 drugs. But those 111, it was the first time anybody had ever published that pricing, and that it was standard aggregate and didn't change pricing unless our costs change. Now,
and these drug manufacturers, they're not sending you rebates.
No, this is all,
none of that noise.
None of that right now. We are going to get it. We're working on that right now. I'm not opposed to rebates as long as we pass it all through and we're transparent about it. That's all that matters. The key, the operative issue is transparency. So that
passing it through to the end consumer, the patient
or the sponsor, whichever, whoever's paying for it effectively.
Right.
And so we published that. And once we published our price list, then all of a sudden researchers were able to say, okay, we know what Medicare pays for this drug or this drug or this drug, or Medicaid pays for this drug. Let's compare the two. And the deltas were insane. And that also led, like there was a study from Antonio from 46 Research who said, in some cases, there are thousands of different prices for the same drug that Medicare pays for, reimburses for. And so that is the first step. So on the drug side, we're doing it. Now, we don't carry all drugs. We're trying. We'll carry every drug we're legally allowed to carry. And we're adding them. I was just on a conversation before, adding more brand drugs to our portfolio, our formulary. And so we'll get there. But that's the first step. So if, using this same example, just for, let's just say we carried all drugs. Let's just say we get there. And we publish our price list. And a city, a state, whatever it may be, knows from their claims data what their utilization is for any particular drug. And they bring in actuarials and they do some research and they use some AI and they extrapolate that to say, okay, within, with a 20% delta, we realize that if we pay for all these drugs from costplusdrugs.com, then there's a good probability that our total drug spend is going to be X. And if they say, well, our budget was going to be X plus 3, wow, that's cheaper than what we expected. Why don't we just buy them all and pay for them all because it falls within our budget? You can start making single payer decisions like that once you have efficient markets and full information. You can decide. You can say, look, it's in our best interest as a company to do this. It's in our best interest as a city to do this. It's in our best interest, whatever, right? As being charitable, right? So there's all kinds of ways that you can start going down that single payer path. You can't just say, to your point, and I agree with you, hey, it's time to go to single payer because that looks like it's better everywhere else. If it looks better everywhere else, why aren't we doing it? That will not work. So if we can do it on the pharmacy side, then we say, okay, what about the care side? And so just like we started off, testing this with my companies on the pharmacy side, we're doing the same thing with care.
How interesting.
so we're going to providers and we're saying, look, I did a little Shark Tank with you and I put on my provider hat and you're a hospital and I understand that you're taking all the patient out of pocket risk. That's insane because you have absolutely no say about the plans they buy. You have absolutely no say about the plans, patients, the deductibles they choose from any given plan. So you're immediately a creditor and you're effectively a subprime creditor because the people who aren't paying for their own health care
They
are the ones
compensate with a larger gross fee because they know they have to compensate with the loss on the
right,
net.
anything, right? So anytime you
And they
lose
also push back on the payers on the patient deductible, which is why hospital patient deductibles are 3 to 5%, and outpatient patient deductibles are as much as 20%.
or higher, right? It just depends. And if you have a high deductible plan, it's going to be higher. And even the ACA, you can choose a bronze plan that has 9,000 for an individual or 18,000 out of pocket max. It's expensive. And who is taking that risk? The provider.
Okay, so finish the thought. So you approach Mr. or Mrs. Hospital. I'm going to pretend to be Mr. Hospital.
Sure.
And you say, do I have a transparency product or service for you?
Okay. Well, I haven't given you the whole pitch yet.
Yes, no, go ahead. Okay. I'm listening.
So first of all, Mr. and Mrs.
Firstly,
Hospital,
you're Mark Cuban, so you're in the room. I'm in
the room, and here's what I say in front of typically a lot. I give these pitches all the time now. I'm like, okay, so we know you're losing $1 to $5 million a year. The rate of your oh my God, I can't think of what the rate that they're not paying you is about 30 to 50%, right? And so you're losing, right? Yeah, your default rate is 30 to 50%. And so you're losing that across the board. So that's bucket one that you're getting killed on. Bucket two is the pre-authorizations, right? Not even so much that you're getting a lot of care denied. It's not even that. It's the game that's played to put you through that pre-authorization process. So you have doctors who are applying to get a pre-authorization approval, and then if they don't get immediately approved for whatever reason, most likely it's expensive, then you're going back and forth with a panel of people from the payer that are saying, no, we don't want to pay this. And what effectively is happening isn't so much that they're not going to pay it. There are plenty of times they don't. And that's, 14% I think I saw for Medicare Advantage. Plenty of times, but that still means 86% of the time they're saying yes. But even in that 86%
it's worth reminding the audience that we do say yes more than any other country.
Yeah. And
we are spending more on healthcare than anyone else. So there's a lot of yeses.
There are a lot of yeses, but
there are also no's.
The time sequence to get to yes
is
a time value of money cost to the provider. Because that means that payer, if that, the pre-auth is for an operation for $50,000 and the payer can make 5% and they can delay a year, right? That's $2,500.
Conditions are getting worse. Emotions are getting worse.
And then there's the overhead associated with the doctor dealing with all that. Then there's, if it's a Medicare Advantage plan, the insurer is dealing with that, but they're used to that. But if it's a sponsor or a private employer, their HR people are getting involved because you've got mom or dad who can't come to work. They're losing productivity because their kid's sick and they're really pissed off that they're going through this whole pre-authorization thing. So there's a second order cost as well, which is the productivity at the self-insured employer, the sponsor. And so you've got all this aggregate cost so we've got the default rate for the provider. We've got the loss of the value of money for the delay on the pre-auths. You've got the cost associated with all the time from the doctors and nurses, so that's eating up a lot of time. And there's also the lost opportunity cost because they're not seeing other patients that could be paying them. And then
so you've defined the problem.
But I'm not done yet. There's more. But wait, there's more.
The problem sucks. What's the solution?
So wait, let me get to the rest of it because you got to see the scale of how much they're losing as a provider. So we've got the default rate, we've got the time value of money and the opportunity cost, and then you've got the cost associated with fighting once for the 86% that gets approved. So on the 86% that gets approved, it's not like, hey, insurance company, we've got a contract for this hip replacement. It's you're supposed to pay us $30,000. Where's our check? No, it rarely works like that. The insurer says, yeah, you did it. Okay, we're not going to pay it. Sue us. Or, okay, we're not going to pay it now. We think it should have been 37,000 minus five, should have been 35,000.
Or you sent in the claim and it was missing a note. Or you
Yeah,
sent in the
or it was,
claim and you sent
yeah,
it in a
or
day late.
you're not
So
supposed to
even
send
if
them
you
on
get the
Thursday.
authorization, the difference between net and gross is still meaningful. I've yet to meet a single healthcare business that gets paid what it charges.
So the question becomes, how much is that? And it's between 2 and 3% typically for every single provider. And so if you have a big hospital network that does tens of billions of dollars in revenue, that's a big ass number.
Yeah, yeah.
And so now the question becomes, how do you take that default and cost responsibility away from the provider? And then how do you price what's left and who should get paid and rewarded for all that? So there's a lot of different ways to think about this. And this is the hard part, right?
Yeah, before you answer how, I want to quickly squeeze in why. So you're Mark Cuban and you've just sold the Mavs and you have built a wonderful media platform that you sold to Yahoo, and you're on Shark Tank, or were on Shark Tank, and you're politically active. You've got a lot of things going on. And all of a sudden, this thing called healthcare, Mr. and Mrs. Healthcare, the couple, they walk into your house and they park themselves on your sofa and they say, we're just full of idiosyncrasies. We're a riddle wrapped in an enigma on top of a paradox. Would you like to spend the next few years inside of this? And you say, sign me up. Why?
Yeah, of course.
Why?
Yeah, because
what grabbed you?
What's more rewarding than fucking up this healthcare system that everybody hates?
I feel the same way. I've spent
Yeah,
the last
obviously
15
you
years.
do, right?
I have to imagine that if I just sold the Mavs.
Well, no, I mean, look, I'm really competitive. Why do I do anything? Why do I keep on doing these things? I want my kids to be healthy. I want to spend time with them. I want to go to Mavs games, and I want to compete. I want to do things other people haven't done or can't do or say isn't possible. And that's fun for me.
And it sounds like price transparency, the ability to compare value offerings from supplier A versus all the other suppliers is an underlying theme, like a principal theme.
Not on value, because value implies that there's a benchmark for what something should cost. Mm-hmm. Having transparency for actual costs that are negotiated makes a market efficient. There's so many markets that are very, very, very efficient where we don't think twice. The market for stocks are for the most part efficient. There's, you can argue some things, but when you look at the price of the stock market, you're like, okay, I'm going to negotiate. No, this is the price. You might wait for it to go up or down, but it's pretty efficient. And, it's priced down to the decimals. Crypto is another market that's close to efficient because you have access to all your data that you need to make a decision.
So the question is, can we commoditize healthcare?
No, it's not about commoditizing it, right? A company.
Can we standardize healthcare?
Well, not even standardizing. There are some things we can talk about there, right? So the question becomes, what are the places where we can simplify healthcare to make it more efficient and more transparent? And that's the ultimate question. That's not easy.
It's not easy, but you would still think plenty of low-hanging fruit.
Well, so when we walk into
30 years ago, we weren't close to this anywhere. But
no,
with the introduction
literally,
of
you want to go
data,
back to 1955 is what you want to do. That's the best way to think about it. When you walk to the doctor says it's $50, and you can either give $50 or give them 2 chickens because that's what you have, and it's worth more than $50, right? You go to the hospital says, this is the cost. Can you afford it? No, then we'll put you on a payment plan because we want to get you healthy and we're willing to take on that obligation. But now there's an arms race, among providers that there's a branding race among providers. They want to be an MD Anderson. They want to be a Mayo. They want to be a UPMC. They want to be an HCA, UT Southwest, Baylor Scott White. Branding matters, and they spend a boatload of money on that branding because they compete for clients or for patients. And there's really just 2 ways that you get, 3 ways, but for the most part, 2 primary ways. That's through your contract with insurance companies, because they cover millions of lives, and that's
Mhm.
your sales funnel, or by all the advertising and
In a
promotion.
tight network with high deductibles
Yeah,
and
and
very little out of network support, they're going to
right.
control the foot traffic.
And that's an issue in a lot of respects for Medicare Advantage and other things. But let's go back to the provider.
Yeah.
So now I walk into the provider and I say, starting just with the lives that we cover, right, for my employees and their families, here's what I want to do as part of a direct contract. I want to do a deal with you where there are no pre-authorizations. I'm going to trust you. You're my doctors. And we're going to have data. I'm going to have all the claims data. So if I see something happening, I'm going to be all over you about it. If there's all of a sudden 50
So this
spine
is a
cases,
self-insured option, right?
self-insured
Fully
option for
funded by the
a
employer.
contract.
You got a green light to provide the care that you think is appropriate. Okay.
Exactly.
I'm
Right.
following you.
So that's part one. Part two is I'm paying you cash immediately. You're not waiting for anything. Part three is there are no deductibles, no out-of-pocket responsibilities that you have with any of my employees or their families. We'll
Okay.
take all of that. So effectively, you're getting paid everything that you're due, which leads to the question of what are you going to charge us? And what we're saying is, depending, it might be, we've had some situations where it's 80% of Medicare if it's truly a commodity, 100% of Medicare if it's close to a commodity, 120% if it's more advanced, 150% in one case if it's super specialty, 250%. But here's the catch, because they're all interested, right? Because they know all the associated overhead, all the administrative costs that you know about, all the revenue consultants that they have to have, all the efficiency consultants, all the AI they're looking in investing. But I'm saying, here's the one thing you're going to feel most uncomfortable with that's the most important. We're publishing these contracts. Every contract we do with you, we're publishing online on costpluswellness.com at some point in 2025 after everything's signed up so that everybody gets to see them. Because if we're truly going to change healthcare in this country and you want to reduce your dependency on the BUCAs, the big insurance companies, and you want to stop that battle you have to face taking on the credit responsibility for the BUCAs in some respects and the patients, this is the path. And so this is what we're going to do. And we're getting yeses. And we're doing this. And now going back to that comment I made about single payer.
Are you getting yeses from groups that feel like their pricing helps their branding because they are part of the bent cost curve?
No, there's expensive groups, right? Where they're premium. There's some that are premium and there's some that, the imaging and stuff like that, where they're price competitive in what's mostly a commodity. So it's it's across the spectrum.
What motivates the CEO to say yes, who's premium?
Because they want to what? Oh, to premium?
The CEO who's premium, who's most expensive, premium.
Why would they say yes to us?
Yes.
Because they want to change the system. They know the system's wrong, and they're betting that once these contracts become published, all the self-insured employers are going to read them and potentially come out and self-contract. Now, I don't know exactly how many lives are covered. I've read one number, 180 million. I've read another number, 50 million. I don't know which is which, but whichever, it's a
big
lot.
Number.
Yeah, it's a big number. And so that's a new sales bundle which reduces their dependency on the BUCAs. Because the reality is the insurance companies, other than for some small group insurance and some direct contracts, they take no insurance risk whatsoever. Everything else is subsidized at one level or another or paid for by an external payer. And so now, hopefully, this gets the ball rolling towards a more efficient market. And
you mentioned this. This has come up that health insurance companies, they don't really experience the kind of volatility you see with other insurance products like property and casualty.
Yeah, because they're subsidized.
During COVID, profits went up, not down. That was an interesting.
Well, people didn't go to the doctors a lot, and that explains
utilization went down.
Yeah, utilization went way down, and now it's popped back up, and they're losing some money there. But that aside,
I will say this: I see in healthcare technology being a great example. And my journey into healthcare technology is recent, right? I spent the first decade of these 15 years really focused on the operations, the guts. And this wave of new, faster, cheaper, better alternatives is pretty recent. But I still think that different segments of healthcare will adopt it at a faster pace than others.
Yeah,
So
for sure. Yeah, I
yeah,
mean, look, there's always early adopters in every segment,
so
whether it's
payers are
technology.
interesting too. So payers are not providers, they're financiers. And you have different segments of payers. You have government payer, you have large commercial insurance payer, monopolistic payer, you have interlocker payer, right? You have the managers, the ACOs, the IPAs, the brokers, and then you have self-insured. I do think this self-insured marketplace, and you would know better than me because I think with Cost Plus, by the way, great name, Mark Cuban Cost Plus, right?
Easy, right? One inch word, one
MCCP.
inch name.
I do think you would know better than me, but it might be the fastest adopter of and
Oh, for sure.
the most performance seeking
Yeah,
segment within the pair community, which is one of the reasons, by the way, why I like diversity, because someone's always faster than everyone else when you have diversity.
yeah,
And you need that fast segment. You need the early adopter to test
for
stuff out.
sure. So when
Yeah.
I walk into a CEO's office, it's like, okay, do you want your employees to be healthier? Sure. Do you want to save money? Sure. Okay, you ready to sign up?
That's the
There's no
pitch.
catch. Yeah,
That's the
there's no
pitch.
catch.
You had me at that.
There's no catch. You know, why don't you do this? Let's start on the pharmacy side with Cost Plus. Go back to your PBM and ask them for a copy of all your claims. And for each claim, ask them for the price of the medication that was associated with that claim, what you paid, because self-insured payer. Unless you have 50,000 lives covered or more, you're not getting that information. And even if
Opaqueness, slowness, lethargy, built on years of oligopolistic behavior. I was just listening to the Bill Gates story on Acquired, which is a wonderful podcast, one of the best series I've seen out there. And I thought, screw it. You know, we've all read about Microsoft 100 times, but I might as well listen to this again. And literally, they're sitting there, Bill and his partner. Was it Paul Allen? I think it was
Paul
Paul
Allen, yeah.
And they're waiting for IBM and Intel to build this microcomputer.
No, I know. I've never
They're like,
Gary Kildall.
surely, any
That's a
minute
Gary.
now, any
Yeah,
minute now, it's coming. And they're in Harvard, and a year goes by, and nothing's happened. And they're like, you know what? Screw it. We'll do it ourselves. And so that's sort of when you deal with these large
getting better. It's even
incumbents,
better than that. That story's even better.
we can wait for the next 20 years for
they license a
transparency
lot
to
of that
come
stuff
from
too.
the incumbents,
Yeah,
or you can do it yourself.
that's what entrepreneurs do. You know, you try to figure it out, and either it works or it doesn't work. Either you make money or you fail. It's really, really binary and straightforward. And look, I'm in a good position where this is fun for me. It's exciting, and we'll see if it works. But going back, walking into a CEO's office, again, no CEO is looking at their benefits costs, which is typically their second largest expense item after payroll, and saying, I'm paying too little.
Yeah.
Or let me invest more to get better care. They're like, this shit's expensive. How
Yeah.
do I save money? And so just by us doing this and handing over our price list, making a proposal, right? Because our prices are the same for everybody, and letting them try to compare to their existing PBM costs, it's insane. I mean,
Yeah.
they can't get their claims.
A lot of people forget that for every 30 cents that a patient pays for healthcare, there's an employer paying for 70.
Yeah.
And that
Or the
employer
government
is
is paying even
motivated
more.
to find solutions too.
Yeah, or the government's paying 80%. You know,
Yeah.
so back to where we are. So dealing with self-insured employers and making it completely transparent, that's the mission. Now we have to build out a much bigger network, and we're talking to big hospital groups. I'm going in front of big groups, and I'm telling them the exact same pitch I just told you. We'll save you on your default credit risk. We'll save you on that 2 to 3%, all the things we talked about.
I think it's a great sandbox to play in. The self-insured sandbox is asking for better
Well,
solutions.
see, but it goes even bigger than that. And so the
Why?
self-insured plan,
Just the fact that you've gone from drugs to provision of care in one podcast tells me a lot about you.
well, yeah, in about 6 months actually. But so we're going out. If we can build a national network, and I think we can, where all these contracts are published and they adhere to the standards and the things that we just talked about, prepayment, all that kind of stuff. Now you're changing hospitals, but we're not really solving the cost problem. We're making it better, and we're
Well,
making
transparency leads to that.
so we'll get there, right? Hopefully. But there's another question, right? So
by the way, you also need transparency in care treatment standards of care, and then you need transparency in outcomes. So it really is a three-legged stool. We
But
could
there's a
all be
lot of
paying the same price, but if we're paying for bad medicine, we haven't
Of course.
necessarily solved anything.
But there's a lot of judgment in that too. No doctor says I suck and my outcomes are bad.
Sure,
right?
but we don't need to spend a lot of money on oxycodone.
No,
Now,
no.
if we could be making our situation worse. So there's the problem with healthcare. The problem with healthcare is that it is probably the best example of an industry. It's almost like a helicopter trying to fly. I have a friend who used to fly a helicopter, and he said the difference between a helicopter and a plane is a helicopter, when you fly, it wants to crash. And a plane feels very differently. It feels like it belongs in the air.
Okay.
Healthcare wants to be opaque.
Oh yeah, because
it's just
everybody who makes money, it's an arbitrage.
Standardizing it is hard. Just like you said, every doctor has an opinion. Guess what? Every patient has a reaction to that opinion. So it's variable on top of variable on top of variable.
Agreed.
And so you end up with a mess in every country.
Let's go back to solutions, right?
Yes.
And this starts to bring in other countries. And so I dug in and worked with an economist like 4 years ago, going on 5 years ago. And I presented one question to him. And the premise was a hospital in Toronto, a hospital in Manhattan should have all the same costs, because the salaries for doctors and nurses are the same in both Manhattan and Toronto. The real estate is actually more expensive in Toronto. Taxes are more expensive in
This
Toronto.
is all news to me. Wow.
Yeah, because I hadn't really I talked about it years ago, but I haven't brought it up when I first did it. And so I'm like, what are the different economics? Well, if you start looking at the economics of nonprofit, they make about, just as of this year, like 4% net, and the for-profits are about 14% net, and whatever, right? On the Toronto side,
the nonprofit's favorite KPI is months of spare cash, which tells you everything you need to know about the space. They literally compare, well, I have 6 months, I only have 2. Oh, I wish I was you. It's just a whole other way of staying alive. Always.
But they still want to build, right? And they still want to grow it. And anyways, that's a different topic. And so, so then you go to Toronto, and they make up to 3%, and they'll lose a point or two if, for whatever reason, things go against them. And so I was like, okay, they're still for profit, right? But their expectations are completely different. But they work to a budget. That's the biggest difference. So the province that Toronto, what province are they? Toronto's in Quebec.
You're asking an Englishman.
Yeah. So no, Montreal's in Quebec, and Toronto's, I don't know.
Close to us.
Yeah.
The one that's close to Buffalo.
Yeah. Well, yeah, whatever province it is, that shows you how geographically illiterate I am.
All right, we're going to ChatGPT. Keep going.
Okay. So in any event, the province has a budget and goes to the hospital and says,
Ontario,
Toronto, Ontario. So they go to the hospital. This is your budget. This is what we can work with. And then the hospital decides
how spend is what you're saying.
Right.
Capitated.
Not just capital, everything, right? So it's not capitated. It's here's your budget for the year. And they decide how much care and what care they can give. And Norway is similar as well, where there's a budget and they work backwards. And then in addition,
so you've completely removed the fee-for-service counter incentive of quantity for the sake of quantity by doing that.
No, not really, because just the incentives are different.
Although I would suspect that they hit their budget every year.
Yeah, of course. But the incentive is
probably a little bit over.
The incentive is to cover as many patients as you can, because you're trying to cover as many patients as you can. And then the incentive on the for-profit or even the nonprofit in the United States is because you're trying to make as much money as you can and trying to get reimbursed as much, or even if it's care for free, you're trying to get payments, right? So, but the question then becomes, if we're trying to get to, and I'm not advocating this, I'm just bringing up the question for conversation. One of the things that the government can do and hire people to do or partner with, is facility management. Right? And so is it within the realm, particularly in healthcare deserts, for the feds now not to take over healthcare for an entire, small town or counties or X counties in Wyoming or wherever they might have a healthcare desert. The idea is you take over the facility and manage the facility, but bring in an MCA or somebody else who can manage the care side of it, so that it's not the feds that are taking care of figuring out how to take care of people. They're just managing the facility and setting budgets for the facility side of it. And so if you start getting there, then you can start delineating and being more precise on the cost of the care side.
Yeah.
And so
I don't think you're going to, it's such a fertile ground, right? You can come up with all kinds of interesting solutions as long as you have the counterpart's attention. And if you're already generating goodwill and economic value for them, economic rent through your drugs alone, you're going to get a lot of attention.
Yeah, so this is like, I'm only having this conversation.
There's a lot of work to do. We almost have to take the actuarials inside of these payers.
This is not something that happens overnight, but part of the conversation was, how do we get to single payer?
How do we educate the free market within US healthcare? How do we educate the public market, the public sector market of US healthcare? And in the process, also educate providers and patients. And so far, historically, we either not had that information, or that information has been concentrated in the hands of a few actuarials working inside of payers. And so there's a lot of disintermediation ahead for you leading that charge. I think you're going to find lots of interesting solutions.
Yeah, I mean, there's a lot of things to try to figure out how to educate people. A lot of people think it's consumerism. Just, give them a lot of choices and transparency on price, and however you can do it on quality of care, stars, whatever it is, and then people will start to educate themselves. Unfortunately, they don't.
But it is a step. It is a step.
I'm not saying don't do.
Stars are better than no stars.
Yeah, look, I'm not saying you don't do it, but it's just like food, and obesity. There's plenty of information about why this food is bad.
That's a good point.
And even people who can afford to make a choice to buy better foods and healthier foods just don't.
Yes. And then all of a sudden GLP-1 shows up and Novo Nordisk is very happy.
Right. And then, there's the cost benefit analysis of, do we just buy out? Do you buy Lilly and or Novo and just give it to everybody for free because the net cost savings in care is enough to pay for it? There's,
Novo was supposed to be a non-profit social good type of business until they realized they could be $500 billion better off by staying for profit.
Yeah, of course, and that's not unusual, but it comes down to, who do you trust? And if you trust your doctor and you listen to if you trust your doctor, there's a better chance you're going to listen to your doctor.
You know who I trust?
Who's that?
I trust you. I trust innovators. I know you're very modest. But I trust innovators that are picking away at these problems and coming up with interesting solutions.
Yeah, but on a day-to-day basis, for someone living in Pittsburgh, Pennsylvania, or Dallas, they don't know shit about me. And that they're not. Maybe my brand helps them.
Mark Cuban cost plus. I mean, it's in the name.
No, it helps. That's why I put my name on it. I wanted them to trust it. But when it comes down to making those decisions about eating that potato chip or having a pickle, whatever, right? I'm not going to influence those choices.
It's a team effort. There are good operators everywhere.
Well, but again,
providers, great regulators, great innovators.
Going back to 1955.
Yeah, talk to me about 1955.
1955, you trusted your doctor. We trusted institutions.
But why 1955? Like, this is pre-Medicare, pre-LBJ. Like, where are we? What's happening in 1955?
Because Back to the Future, I think, was 1955.
Okay, you've done your research.
No, I mean, I watched.
Was there a doctor scene in Back to the Future?
No, there wasn't. But Dr. Brown, whatever the guy's name was.
Yeah, I think he was a nuclear scientist, if I'm not mistaken.
And probably everything else too. But it was a lot simpler back then. Much, much simpler. And,
but I'll throw another but on top of your but. Annual rate of inflation in US healthcare in 1950s, 60s, 70s, 10%. It's not like we had the problem solved back then. But that's fine, right? The only difference was we were starting at a much lower numerator, right?
Yeah, lower benchmark. All good, right? But it still comes down to trust. People want to trust their doctors, and they don't trust anything else in the system. That you just don't. You know that your bill is going to
But that's
be
emotional. Of course, you need to
no,
trust
no, it's
doctors,
factual.
but
It's not even
doctors
emotional.
alone are not going to organize a $5 trillion industry. It just doesn't
Well, no, but
exist.
the doctors are bitching themselves, and rightfully so. You brought up the point that their wages, particularly through reimbursements,
No,
haven't kept up with inflation,
no.
right? I'll add another thing. I would make all public med schools free, so
So
that
now we're getting into, look, I told you before that healthcare is simple and we solved it. Couldn't be more far from the truth. In fact, healthcare, you pull on any string and you're going to find 500 unbelievable entrepreneurial opportunities
oh, for
falling out.
sure. But the question becomes:
Education
is
is
it
another
fundamental?
one. Another
But
one.
but is it a foundational problem that has downstream benefits, or is it an arbitrage where you're just taking one little segment and trying to take 2% and only save 2% on this one element and use AI, da 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 da.
They all seem critical. The fact that we have very little supply in clinicians, and by the way, it's a riddle. It's not an exercise in negligence.
Well,
How do
but
you train the world's best doctors and do it in less than 10 years?
see, I would say it's not the. I can't speak to how the quality of the education. I'm not going to try to get in there. But what I do know is the amount of debt that so many doctors take on influences their decisions, and it influences
For sure.
what
But
specialties
so
they
does
go
the
to,
time and the
where they
hardship.
work, how much they have to charge.
Yeah.
So if you said to all the public health schools, medical schools, there are 97,000 medical students right now, 97,000. And if let's just say at if all of them were in public med schools and the
It
cost is
would help. But
well,
behavioral economics
just look
being
at
what it
it
is,
just look at it relative numbers, and it's $60,000 a year for tuition, another $20,000 for a stipend to do whatever. Now you're at 80,000 times 100,000. That's $8 billion a year. So is it worth spending $8 billion a year to put ourselves in a position where, hey, your care was free? Part of this deal is you're going to be, a primary care physician. And
I'm
this,
with you. The behavioral economic math is formulaic. There are
yeah,
inputs. One of the
it's
major inputs is what did it cost me to get here? Another one is how much time. Another one is how much hardship. And if
yep.
you add all those inputs and you get a large enough number, the output is I better get paid a lot of money.
Yeah,
And
for
now I'm
sure.
incentivized to do more. And that's not necessarily what you want every doctor to focus on.
No, and you don't want all of them. First of all, you don't want to exclude doctors who can't afford it in the first place.
Yeah,
That could be our best
that's
doctors.
another point. But that also speaks to supply, right? They could want to all they want, but if the schools only have room for 95,000, it doesn't make a difference.
And that's great, but if they can't afford it and they, then again, trust the school to pick the best candidates. But that said, if we had, 97,000 doctors coming into the country every year that didn't have all this debt, the decision-making process all downstream changes. All the vertical
Yeah, but here's
integration.
another solution. Most markets, excess demand, insufficient supply, you see supply go up. And what do we see in education? Capped supply.
Yeah. So, so that is one
Riddled
of the,
inside of an enigma on top
yeah,
of a paradox.
just like you were saying. And so, if they put me in charge, that'd be one of the first things I would do, just because it just simplifies all the downstream problems. The second is require all contracts to be published, anything healthcare
That's
related.
huge. That was
You know,
supposed to happen with the Transparency Act.
yeah,
Not
that I
really.
don't know. Then
Nothing's changed.
the third
They're
thing
still
I would do
obfuscating.
is allow all, not just patients, but the payers and the providers and whoever the patients choose to own all the data. So if I'm a self-insured employer, I should own all my claims data, period, end of story, so I can focus on my wellness. And here's a little fact for you, a little known fact. The pharma manufacturers, they don't even get all their claims data. So they have no idea, a GLP-1 manufacturer has no idea about the breadth of claims. And I'm not talking about individual patients.
Perfect example of what you're saying. Rocket
Yep.
Money. Rocket Money. Do you use
And
Rocket Money?
so,
Have you heard of it? It's an online tool to manage your bank accounts.
oh no,
Right?
Rocket, yeah, because Rocket
Yes, it
Mortgage, yeah, Rocket
aggregates from
Mortgage.
American Express, from Chase.
No,
And what does it
that's
do? It
Rocket
tells
Mortgage.
you whether you've
That's Dan
overspent.
Gilbert. He owns the Cleveland Cavaliers. That's my
Has anything like Rocket Money been even imagined for healthcare spend by
yeah, there's
consumers?
tons. There are tons of applications that allow you to try to take control of your own personal data. But for the payers in
Where
particular,
where are they going for that data? Are
well,
they
they
going
get
for
it
your
from their doctors.
primary
Like I use
payer?
Quest. Like you can even integrate your Apple Health ID into your providers. So there's Quest, there's MyChart from Epic. There's a whole bunch of options there.
Is it effective? Is it exhaustive? Does it
No,
cap?
it's effective for people who want to use it. But what I'm getting to is a different issue, right? And so you're looking at the patient level. I'm looking at the payer, or in this particular case, sponsor, the self-insured employer level, so that they can start to put together wellness programs. And so by having these contracts and all the data available to the self-insured employer, you start changing some of the methodologies. You start changing the wellness efforts that are available to those self-insured employers.
I still think there's a lot of silo data out there. I mean,
Oh yeah, for
do
sure.
you turn to your payer, go online and check in a beautiful dashboard what Mark Cuban's healthcare portfolio looks like? Has United trained you? I don't know if you use United or Cigna or Anthem or whoever. Are you turning to these payers and educating yourself in what you're doing with them being your partner, down this healthcare journey? Or is insurance something that you just try to ignore and basically you get through the mail, explanation of benefits, and
That's
other
a
than that, try to
whole
avoid
different
it?
thing, right? Should the insurance companies be the ones aggregating that data? And the answer is no. And
No.
that's the point, right? It shouldn't be any of the Buca insurance companies. It's so the pharma manufacturers should have access to their version of the claims because they need it to analyze to make sure there's not something funky happening with their medications. The self-insured employers should have access to that data because they want to determine that there's not an opioid crisis in Bloomington, Indiana for their 2,000 employees there or whatever, and they want to look for trends, and they want to make a determination if the GLP-1s are working or not working. And then the patient should have them, but they should be able to get them from, either their hospital, their provider, and or their employer.
Does Cost Plus build that kind of dashboard interface,
No,
or do you
we're lean and
outsource
mean.
that?
No, we're lean and mean. That's something, people buy from us on a cash basis or work through their payer, their
You've
insurance
got
company.
enough to deal with.
Yeah, I mean, there's somebody that can cover that, but the key element is the availability of data should not be the responsibility of the big insurance companies.
I agree.
You
I
take that
agree.
out,
There's
and that
not much
enhances.
innovation that you want to leave at the hands of very large
No,
companies.
but it goes to what you were saying in terms of
This is the
education.
innovator's dilemma lesson, right?
Yeah, in a lot of respects, right? But it goes to what you were saying about education. If my employer, who's paying my premiums and maybe paying for all of my healthcare with no out of pocket for me, has all that data, and there's a third party that we can hire and aggregate that data to educate the employee, great. Or if my doctor, the providers that we contract with, they want to do it, which is more likely because they have case management people that do all this stuff, great. But you have trust and you have availability of the data and you have affordability, and that gets you better outcomes. So there are paths to deal with all this stuff.
I can't believe that I'm speaking to the former owner of an NBA team.
Well, I still own the 27%, so I'm not totally former.
No, I know you're not totally former majority owner.
Right.
And at this granular level of healthcare dysfunctionality, it's such a beautiful, I mean, you're such a wonderful example of pivot, a successful pivot from one to the other. So,
well, I mean,
questions.
Plus has been good, but we haven't done shit in the big picture yet. So, and there's a lot I have to learn.
Well, a few questions relating to that. One, by the way, your big picture is probably bigger than most, so it's all relative. How does NBA operations, how does digital media operations, how does it equip you for healthcare operations and innovation? What do you see that's similar, or is it a world apart?
No, they're all similar. They're all the same. And so 95%.
Problem solving. Speed to market.
It's not just that. You just have to know where the incentives are and what the processes are. Because the incentive for every business is to make more money, to keep their customers happy, and to go get more customers. So it's a virtuous cycle. And where you can take out pieces, where you can become more efficient, where you become smarter, where you can give yourself a competitive advantage, that's a win. Whether
I call it problem solving plus reward, which is different than government, which is just problem solving.
Yeah, I mean, again, it just depends on who's doing it and how qualified they are. But, whether that's a hospital or an NBA team, or it's a government entity managing something, it's all the same. Except the government entity isn't trying to maximize profits, they're trying to minimize cost. If if everything's aligned, if all the incentives are aligned, that's the hard part. That's always the hard part. When I got to the NBA, I used to tell them NBA stood for nothing but attorneys because they ran everything like it was a law firm. They weren't trying to
You found
optimize
another
anything,
dysfunctional industry that could use some change.
and they still are. But I did my
But
best.
they experienced you.
Yeah, for better or worse. Some will tell you worse. But the other side of it is you have to know what business you're in. The NBA thought we were in the basketball business. We're not, right? We're in the entertainment business. We're in the experience business.
This
You
is
don't remember?
similar to Sheldon and Vegas,
Yeah, for
right?
sure,
We're
100%.
not really in the gambling business. We're in the entertainment business. We're in
When
the conference business. We're in the education business.
exactly. Well, it's the same for hospitals too. They're in the wellness business. How do you make as many people
Oh, that's going to be
healthy?
very difficult for them to appreciate.
Well, but how are you going to, and they get that.
Wellness is a very broad net.
It's just you've got, from my perspective, then I look at all the processes and I say, where are the incentives in each of those processes, right? No one thought, like when I started talking about, at least that I'm aware of, when I started talking about the default credit on patient out of pocket, people in hospitals talked about it, but nobody had talked about it publicly.
Yeah.
And I was shocked.
Yeah.
And I was shocked it hadn't dawned on me years before. Yeah, I have a deductible. If I don't pay it, who pays for it? You know,
This is the new age of podcasts. You actually get to talk. And when you talk, people listen. When I
I
talk,
don't know
not so
about that.
much. That's why you being here is great.
I don't, but on that point, I've got to get to my son's baseball or basketball game.
I have taken too much of your time, Mark. I feel
It was
bad.
fun. I really enjoyed it. And now knowing that you're friends with Savan and Patrick,
Patrick,
yeah, that's big
I'm
time.
going to be with them in 1 week.
Well, tell them what you think about this podcast.
I'm going to force them to listen to it.
And the
Mark,
better part is I've been saving all this up before I go to Patrick.
let me tell you,
Show.
I love your brilliance. I love your passion. I love your energy. I love how you commit to things. It sounds like you're all in on this healthcare. I don't know how, with all your other interests. I don't know where you find the time. You're probably sleeping 0 hours per night.
I get my 5-6 hours.
And everyone should appreciate that this country was built by innovators and dreamers who actually get stuff done. And so it's just a pleasure to see one in virtual person.
I appreciate it, Roy. Thanks so much. I really enjoyed it. This was fun.
Thanks, Mark. Take care.
Uh-huh.